introduce Professor Jafar Golzarian from Minneapolis. He's a young guy. He's just starting doing PAE, and he's going to show us how he improves the technique, especially by using different material and different optimization of the machines.
Thank you, Hisham. Again, a pleasure to be here, and we're going to talk about some of the technical aspect and how imaging can help with getting better outcome. Of course, imaging in a lot of situations where you have pre-procedure CTA imaging is important because that can show some of the patient that can be excluded, but also show the anatomy and sometimes get you to a faster procedure time. But however, you need to know that doing imaging with good quality is very hard, and interpretation of that is not going to happen the same thing in every institution. So I would say it's very operator-dependent procedure, CTA. Access, we all discuss about people who are femoralists and people who are radialists, the people who prefer going from the arm. There are some advantages. Mostly the fact that the patient is discharged without too much need for bed rest. But the problem is the height of the patient, the catheter length, sometimes the stability is a problem. And also I think there is some learning curve to that. And there is something that we don't talk about it, is the incidence of stroke, especially if the patient is not heparinized, is not rare, although it is asymptomatic. The type of, if you go from femoral, I usually use a rock catheter, and you can see with the rock catheter that sometimes you just get at the origin of the vessel, and if you can, you are able to work it well, turn it around, you can really easily catheterize the origin of your vessel. Usually, if you don't have the rock catheter, Cobra is a good choice to go up and over and then use the Waltman loop to come back to the other sides. We usually start with the oblique view and then finalize it and embolize in the AP view. For PAE, use of microcatheter is important, and more the trend is going to the smaller size. You can do the majority of cases with 2.4 microcatheters, but the smaller microcatheters are also very useful in smaller vessels. And you can see here the case where you can see actually the size of the vessel is almost as big as the 2.8 microcatheter. There are different type of microwires. I usually go with the cheapest one and the one that can get you to the majority of cases. Run through is a cardiology workhorse microwire that is very useful. If that doesn't work, I usually take a Transcend 14. And then there are multiple other wires that you can familiarize yourself with them. There is a discussion about perfected technique, which means you go proximal, embolize proximally, and then go distally. I would always say if you can go as distal as you can and pull back proximally is the best technique. But sometimes you get to your artery at the origin, you are afraid of a spasm, you are afraid of losing the catheter, then you can embolize proximally and then go try to go more distally. But be careful, because when you do that, you are changing the pressure and flow and resistance in the vessel. So if you inject with the same force, you may open anastomosis, like in this case where before embolization you don't see any anastomosis. After embolization, when you go more distally, you start to open the anastomosis to the vesicular. This is another case, same thing. So just be careful on the force of injection. Coils and plugs, of course, for flow redistribution or redirection is important, and especially to protect the essential organs from non-target, such as bladder, rectum, and penile tissues. You can use pushable, detachable, or plugs, whatever works well for you. And always consider that in those situations you want to do a good packing. So there are some examples like this one where you see there is a major accessory pudendal artery, while you see some branches from here going to the prostate, but also these arteries are also going to the prostate, and selective catheterization. All of this is difficult, and sometimes you will have refluxes. In this situation, the best thing is to coil this accessory pudendal and then finish the technique. The coil out technique has been something that was proposed by Ari Fishman, and we started to do that at the university, and the goal was to prevent from the vessel to reopen. And I don't say it's a bad thing to do, it's just you have to be very careful when you do that. You have to pack exceptionally well, because if you don't pack it, it will recanalize, the patient come back with symptoms, and you can't get back into it. So be careful if you do that technique. So I'm going to pass to the cone beam CT, importance of the cone beam CT. If you have some fancy machine that can give you cone beam CT and can help you with the vessel mapping, it's great. If not, you need to use cone beam CT to make sure, and I know some of my friends have different opinion, but in general, it's a safe way of making sure you don't have non-target. It also shows the extent of prostate that you are covering, and can give you a hint about the fact that there may be some vessels that you are missing. So there are a lot of publications, and this meta-analysis was very important that showed, this study, sorry, it was not a meta-analysis, that shows cone beam CT provided close to 60% of information that was not found by DSA alone. So the way we do the cone beam CT, for vessel mapping, we use an injector, but when you are in the vessel that you want to embolize, I just inject hand injection, 3 cc, diluted contrast, and during the rotation of the CT, you make sure that you cover all of the parenchyma, all of the rotation. And I show some of the example where experienced physician, like here, Dr. Rustam Begi, went for this vessel as considered as the prostatic artery, catheterized here, and did a cone beam CT that showed that he's actually majorly in a bladder vessel. And the example like this are not rare, so you need to be careful about your endpoint and where is your microcatheter. Using Embo Assist, we have a GE machine that can allow us to, with this technique, to get really nice imaging of the vessels. And we have seen in our lab, comparing with my experience previously with the university, that we have significantly reduced not only the dose, but also the time in the room, the dose of contrast, the dose of radiation, and our outcome also has improved by using this combination of cone beam CT and vessel mapping. So this is a patient with this DSA. Let me see if I can activate it. So looks at this, it looks like a very simple prostatic artery. We did the cone beam CT. You can see the rotation. The patient hand should not come out. That's because of the large bore catheter. This is as quickly as you can get. Really, within 2 minutes, you can get the images like this. And then we go and click on the prostate and click on the artery on top, and you can find the origin. And you can see when you rotate around it that there is an acute angle in that artery, which makes it catheterization a little bit more challenging. Then you can use that as your roadmap without any extra contrast injection, and then get to the vessel and go selectively. So here there is a case where I embolized the left side without any problem. We came to the right side. You can see the cone beam, the DSA in the right side. When you look at that DSA, we thought that the main vessel going to the prostate is this one. And I think that's most people would go for that as the main vessel. We did the emboassist that showed us a second vessel that I thought it was mostly a bladder artery. The cone beam CT selectively showed that you see the prostate, but you don't see all of the prostate here with the injection. So there is area that is missing. So we went ahead, catheterized. You can see here the area that is missing. So we know that there is another artery there. We went to selectively catheterize that vessel that goes to the prostate. When you look at it, it looks like a juicy prostatic artery. Very often, without cone beam CT, I would stop here. Then we went to the other branch that emboassist showed, and you see that it's going to revascularize the part of the left side that we already embolized, which shows also a good parenchymogram here. And then we went back and did the corona mortis catheterization, and we found that this actually shows the parenchyma, the area that was missing on the cone beam CT. So the cone beam CT is very important to identify all the vessels, and also if you are partially embolizing. One fast comment on mobile versus fixed unit. I think the fixed unit should be the go-to, but if you use mobile C-arm, try to use the mobile C-arm that can give you the cone beam CT. And if you don't have a cone beam CT, please don't embolize unless you are 100% sure you are in the prostatic artery. There are a lot of sue cases going in the US because of that. So in conclusion, imaging modalities can help you a lot to improve the technique, the outcome, and radiation exposure to the patient. Thank you for your attention.
Thank you, Dr. Jafar, for interesting, great presentation as usual. Let's move to the next speaker, Dr. Karim Abdul Tawab, Ain Shams University, and he is one of the